Right, so here we are to talk about elbow dislocation. I've just taken a moment or two out of my run. I can't beat Bates for inappropriateness, short of broadcasting this from a kind of 16-person barbecue or something. I'm not in a cemetery or a laundromat. Come to one of my favourite places and taking a few moments out to talk to you about this young lady. So we're just on the edge of Hoveringham at some man-made gravel pits actually that have since been flooded into one of the nicest bits of lakes I've ever seen actually. So yeah, talking about the young lady, so the x-ray that we showed, which hopefully should just be up here now by the magic of the internet and all that kind of stuff. The major mistake with this young lady was failing to pick up her significant injury. You can see on the x-ray that she's got a depressed radial head fracture, that she's got a bony avulsion on the lateral side, and that she's also got the old seagull sign there. So she's got a complex elbow dislocation with some signs of incongruity. When you talk to her, and I actually shared that picture on the webcast, she is able to demonstrate that her elbow was completely out of joint. So where do we go from there? Well, unfortunately, she was treated non-operatively and was brought back to my clinic around about 4 to 6 weeks later with a sensation of instability. We talked a little bit about how you might investigate this, and for me the only real investigation for a patient who may have dynamic instability is a dynamic test. So until we get kind of stress MRI or something crazy like that, it's basically to theatre, anaesthetic, and stress it in both directions. Have a look, see whether you can make it pop out, number one. Number two, see whether you can get any incongruity. Number three, look for rotation. So when you're doing a EUA in theatre, it's important not to do it in full extension, because you get elbow right out like that. You lock the olecranon into the olecranon fossa, and there's no possibility of making it unstable. Once you've done that, if you can pull her out, then the take-home messages are any kind of instability, then you have to have a plan, and that plan is a stepwise reconstruction. And for me, I always start at the front, mostly because once you've repaired the radial head or you've repaired the medial structures, you can't get to the front, and I like to repair the front from behind with two drill holes. If Batesy was here, he'd say all the best things happen from behind, but I'm not that kind of guy, so I definitely won't. Then you're basically doing this anti-clockwise for a lateral instability. So you're looking at the capsule from the front, you're reconstructing all the way around, and this lady had a full house, as you can see on the x-ray, which hopefully has appeared just here now. She had all of her reconstruction done, and that left her with a completely stable elbow. She was able to move the elbow right away, and whatever kind of reconstruction you do for post-operative range of motion, you should be able to get them actively moving immediately. I tend to avoid torsion for up to 12 weeks, but they do active and active assisted and passive range of motion almost right away. I don't use elbow braces, I don't use anything other than the sling for comfort, and really that's how you get your best results. And that's about it, really. Think about instability when you see the elbows. Think about those minor signs, and make sure that you really are treating the patients when they tell you they've got something wrong, like they actually have. Ta-ra.